I'm very impressed by the work that's been done here, and hopefully the things that I have to say about obesity are going to pique your interest, and I very much look forward to the discussions. So here are my disclosures, and had I shown you the slide a couple of years ago, there might have been maybe one company on this. Now there's a growing number, and in fact I think it's fair to say that virtually every large multinational pharmaceutical company is currently entering the area of obesity. And that is proving to be certainly a game changer for our patients, but I think it's also being a major game changer for the practice of medicine. Now, obesity, as many of us know, is associated with a large number of conditions. Now, there are conditions which are directly related to obesity, which means that when you have obesity, you are much more likely to get the condition. But we must expand this because, as any clinician will tell you, when someone has obesity, managing almost any other condition, whether it has anything to do with their obesity or not, becomes more difficult. The response to treatment is more difficult. Managing these patients becomes more difficult, and the COVID epidemic was a good example of that. So there is no field in medicine which is not affected by the fact that we have far more people living with obesity than ever before. And I know that the focus here, of course, is on cardiometabolic disease, and I think it's fair to say that over 2/3 of the deaths of cardiovascular disease are directly related to the comorbidities and to the problems that people living with obesity encounter. Now, obesity has long been known to be a risk factor, but there really wasn't very much we could do about it, which means that lots of our approaches to preventing and treating a cardiovascular disease was very much focused on treating some of the other factors, which include things like hypertension and, of course, diabetes and cholesterol, etc. But we really did not have a good way of addressing and managing obesity, although it has long been recognized that obesity is actually one of the key drivers of all of these complications. You know, we have gaining weight makes your blood pressure go up. It can increase your risk for diabetes. It affects your lipids. It affects inflammation and a lot of other things that actually ultimately will lead to cardiovascular disease. Now, when I first started out in my area of medical training, this was back in the 70s, that was when targeting hypertension actually became possible, because there was a rapid development of medications that could address hypertension. We then started targeting lipids, and many of you might remember the introduction of statins was really one of the landmarks there. Then the focus shifted really on things like coagulation, so the fact that we now routinely prescribe things like aspirin to people who are at risk of cardiovascular disease or have cardiovascular disease, that became a focus. Glycemic control was actually pretty late to the game, because evidence that managing diabetes would actually reduce cardiovascular risk was surprisingly, it took a long time for that to be established, but that has been the focus for a long time. And I think it's fair to say that finally we are now entering an era where the medical management and medical treatment of obesity is now possible. And I'm going to provide you a little bit more details on that. This is just an example of why I said that, because we now have evidence from large clinical trials, and SELECT is probably the largest one to date, that has clearly demonstrated that these medications that have now come onto the market largely for the treatment of obesity actually reduce cardiovascular risk by almost 20%, and that is on top of all of the other medications that these patients are taking, so their blood pressure lowering medications, their statins, etc. Now, obesity is not as new as people might think. In fact, here's an editorial back from 1974 where the theme of the editorial here was that obesity, which was already increasing in prevalence at the time, said that this is largely preventable. But I want to draw your attention to a very important sentence that was in this editorial, and that was, probably the obese adult can never be cured, but most obesity could and with care be prevented. Now, I want to focus on this cannot be cured, because I've been doing obesity medicine now for the past 30 years. We still haven't cured obesity. And we still, until very recently, have not done a very good job of managing it clinically. Now, the global burden of obesity is increasing. There is, in fact, not a single country anywhere on the planet where obesity rates have started going down because of any kind of public health measures. And believe me, people are trying. There have been many countries in which we have had policies around, limiting access to sugar-sweetened beverages, and there have been exercise benefits and all kinds of policy attempts, but none of them have actually led to a significant reduction or have even managed to slow the epidemic. And the reason for that is probably because the causes of obesity are probably more complex than most people think of. So when we think about the causes, obviously there have been important changes to the food environment. There have been important changes to the, to the cityscape. People are less physically active. But we also know that there's a strong link to the social determinants of health. We don't talk a lot about the psychology or mental health, which is a huge part of the obesity epidemic. But we have to remember that all of these influences are working or are leading to obesity largely because we are biologically, or most of us are biologically predisposed to obesity. If you do not have the biology that allows you to gain weight, then of course there will be no obesity, no matter what the environment is. And those people exist. All of us know these slender, skinny people. They have, they eat all day, they never exercise, and yet they never seem to gain weight, right? So we know that if you don't have the biology for obesity, then you can be exposed to this type of environment and you will never actually get obesity. Unfortunately, that's not true for most of us. And we have known about the importance of biology in obesity for a long time, because this goes back to the to the 70s when Stunkard published these data on twins. So he did twin studies, looking at twins who were reared together and looking at twins who were reared apart. And the gist of this surprisingly large body of literature actually is that when you look at monozygotic twins, these are twins who are identical, they share the same DNA. Even as adults, they basically look exactly the same, right? Versus if you look at heterozygous twins, these are twins who are not genetically identical, they can vary largely in their shape and size. And you can see this in families very often. You will have a family, there's 4 kids, 3 of them, no problem. One of the kids, has an obesity problem, and that is largely genetic. Now, we understand that there are many, many genes involved in obesity. In fact, now, currently, there's more than 1,000, almost 1,400 genes that have been associated with increased risk for obesity. And if you were to guess what are these genes and what do these genes do and how do these genes contribute to obesity, and even ask the question, where are these genes expressed? You might guess, well, maybe in your digestive system, maybe in your liver, maybe in your fat tissue, maybe in your skeletal muscle. But the interesting thing is that when you look at the tissue expression of these genes, virtually all of them are expressed in the central nervous system, which, to many is a surprise. And when you look at where exactly in the central nervous system these genes are expressed, you find them in 2 areas of the brain. One of them is the hypothalamus, and the other one is in the hippocampus and the limbic system. So these are the 2 parts of the brain where there's the highest expression of genes that predispose people to obesity. It's not in your skeletal muscle, it's not in your fat tissue, it's not in your liver, it's in the brain. And what we have come to understand over the last several decades now is that obesity, like almost, or body weight, like almost every physiological function, is tightly controlled. There is a very complex biological system that exists that really controls body weight, controls ingestive behavior, controls food intake, controls exercise, energy expenditure. And this complex system has evolved for one single reason, and that is to protect you from weight loss. Throughout history, losing weight has never been good. Anytime you were faced with the challenge of finding food, or you were faced with the need for increasing physical activity, your body had to have a mechanism that would conserve calories, protect you from excess weight loss. And even today, when you have a patient in your clinic who's losing weight for no good reason, you don't have an explanation for why this patient is, it's never a good sign. So the problem you're up against when you manage obesity is that any attempt at weight loss means you're going to be fighting your biology. And this biology is not only complex, it is extremely powerful, and it is going to make sort of permanent weight loss extremely difficult. Now, when I first moved into the field of obesity, I trained as a nephrologist, and for the first 15 years of my academic career, I was working as a nephrologist, and then I became interested in obesity largely because of its connection to hypertension, and I went to my boss at the time, and I said, I'm interested in this obesity thing, and I think, we should be doing some research. And my boss at the time actually warned me. He said, Dr. Sharma, if you want to be taken seriously in academic medicine, forget about this obesity stuff, right? Leave that to the dietitians, leave that to the exercise people. That is not a serious field of medicine to be in. Now, fortunately, I had the opportunity of getting some grant money, so I was able to start some projects, and then over the last 20 years, I had the opportunity of actually creating, some infrastructure and a clinic on obesity in Canada. Now, the problem that you're up against when you try to manage obesity, and everybody who has ever tried to lose weight, is the following. And that is, no matter how you manage to lose weight, and you can do this on any method. You can do, you can do keto dieting. You can do a paleo diet. You can count your calories. You can have an exercise program. It doesn't really matter. Most people who have successfully lost weight will tell you that within the first 12 months after losing weight, they come back to the weight that they started at. So the problem is really not losing weight. The problem is, how do you lose weight and how do you keep it off? And that has always been the challenge in obesity management. And in fact, even in all of the randomized controlled trials that have been done, and there have been a lot of these trials, using all kinds of diets, with and without psychological support, with and without exercise, different types of diets, everybody loses weight. And when you look at the people, 1, 2, 3, 4 years after this exercise, almost everybody is back to where they started. And this is not because people are not motivated, or people are not trying, or we still haven't found the right diet, or we still haven't found the right exercise. No, this is because the biology that I just talked about is so powerful that no matter what you do to reduce your weight, you're going to be fighting your biology, and your biology at the end of the day will win it. Now, of course, we know people, everybody knows someone who has managed to lose a significant amount of weight and has been keeping that low weight for many years. And in fact, in the US, there's something called the National Weight Control Registry, which I find funny because the US does not have a gun control registry, but they have a weight control registry. And in this registry, they follow people who have successfully lost weight, and then they ask them every couple of years, so what are you doing? What is your magic formula? How are you managing to do something that 19 out of 20 people cannot do? And the answer is pretty simple. These guys are limiting their food intake. In fact, they're limiting their food intake to 1,400 calories, which is probably what I had for breakfast. That is not a lot of calories. On top of which, they are doing 400 calories of exercise every day, which means they're basically living off 1,000 calories. Now, in order to do this, we are not talking about lifestyle change. We are talking about dedicating your life to lifestyle change. You're changing your life. And when you meet these people, they are often not the most pleasant people to be around, because they are so focused on managing their weight that there's no room for other activities in their life. They can be pretty tiresome. And I've met a lot of these people. So what basically happens, and this is just a short summary, is that when you take someone in your clinic and you tell them, you please go and lose weight, they go and lose weight. Immediately, the biology that I talked about is going to kick in and will do the opposite. And you can measure exactly what happens. You can see that all the hunger hormones go up, the satiety hormones go down. At the same time, their energy consumption goes down, which means that now they're burning fewer calories than they were burning before. That is the body's way of resisting weight loss. And it is the same mechanisms that actually make it much easier for someone who has lost weight to put the weight back on. Now, the brain, of course, is the central organ in all of this. And now you can think simply of areas of the brain and what their role is. Now, the first part of the brain, and this is the hypothalamic part, this is the homeostatic part. This is the part that is responsible for controlling your body weight. But then there's the second part, which is the hedonic part, which is the reward system. The reward system does not care about your weight, but it is more powerful than the hedonic system, and you will experience this. When you're at the buffet and you have eaten all you can, and you're feeling completely full, that is the homeostatic system saying, enough. And then you see the dessert, and then somehow that you can still manage. That is your reward system saying, no, come on, we will make room for this also. And then we have the the frontal cortex, which is really where you make conscious decisions about your food intake. So when you're standing in front of the buffet deciding, which foods are you going to take, how much are you going to take of which food, when you send patients, that is where you make conscious decisions, right? That is the frontal part of the brain. Now think about our conventional approach to obesity management. You send someone to see the dietitian. What is the dietitian telling them? Please be mindful when you eat. Please plan your meals. Please make the healthy choices. Please keep food records. Maybe count the carbs, count the calories, all of that. That is all frontal lobe. That is not changing the biology. That is using willpower to try and overcome the biology. When we talk about people who have emotional eating, so now we're talking about hedonic eating, things become a lot more difficult because now we are talking about a completely different part of the brain with completely different biology that is much harder to control. And so far, the only people who have actually been able to change the biology of the homeostatic system, which is the key system in all of this, were the surgeons with their surgical procedures. Now that we have the medications, we are finding that we can actually mimic, using medications, what happens to people after bariatric surgery. Now, I want to talk very briefly about some of the issues that we are up against when we look at this from an epidemiological perspective. So I still believe that one of the major drivers of the obesity epidemic worldwide is lack of time. Lack of time means lack of sleep, increased stress levels, increased hedonic drive, and that is increased consumption of unhealthy foods. So it starts, fast food is a time problem. It's not a food problem. If McDonald's took 45 minutes to serve the hamburger, nobody would go there, right? The fact that it comes pre-chewed and you can eat it while you're on the phone, while you're yelling at the kids, while you're driving your car, that is actually the problem. You live in a society of grabbing bites. Here's another one we don't talk about often, and that is decreased birth rate. Worldwide, birth rates have gone down, in some countries very dramatically. The problem with that is not only that the age of the parents has increased, the number of offspring has decreased, which means you have reduced childhood density. When you only have 1 or 2 kids, there is helicopter parenting. You don't let the kids go outside. They are being pampered by their parents, by their grandparents, by everybody. There's a decrease in free play. So this is a societal change that has happened demographically virtually in every part of the world. Now, coming back to obesity as a disease, virtually every organization has now declared obesity to be a chronic disease. And every guideline on obesity now accepts the fact that when you're treating obesity, medication has to be part of that treatment. When we look at the Canadian guidelines, just as one example, we can see that, of course, we still want our patients to change their diet. We want our patients to be more physically active, but we also recognize we have to support these patients. And what we're finding is that with the proper behavioral interventions, medical interventions, and bariatric interventions, surgical interventions, we are actually able to make the patient or we are able to facilitate the patient's change in diet and also their changes in physical activity, which becomes possible once the patients have actually lost significant amount of weight. And what we have learned now is that everything the bariatric surgeons have been telling us about the benefits of weight loss, over the past 40 years, they were the only ones who were providing definitive obesity management, because only the surgery was, where people could lose 10, 15, 20, 30 kilos and keep them off over periods. And they have been telling us that with effective obesity management, you can reduce diabetes, you can get remission, you can improve quality of life, you can reduce everything. And in fact, now that we have the medications and we can finally do all the large randomized controlled trials, what we're learning is that everything that the bariatric surgeons have been telling us is true. And there was only one small question mark left on this slide, and that is the cancer prevention, because from the bariatric surgical literature, we know that patients who have had bariatric surgery, their cancer risk is reduced by almost 60 to 70%. We have not yet seen that with the medications, largely because those trials have not been done. But I would be extremely surprised if at the end of the day we find that losing weight with these medications does not also prevent cancer. And we are going to have a lot of opportunity to test these hypotheses because, as I mentioned when I started, that today every single pharmaceutical company on the planet is involved in trying to find medical treatments for obesity, and the pipelines are full. There's more than 140 compounds that are now currently in clinical trials for obesity, so this is going to get extremely crowded. Now, having said that, how do we solve the problem? If you look at this from a population perspective, I think we have to address the time issue, the stress issue, the low sleep issue or lack of sleep issue, the low birth rates. All of these have to be addressed at the society level. I have no solutions on how you can do this. I cannot think of policies that anybody can take that are going to make this possible. But those, to me, are the root causes of the obesity epidemic. We can increase active commutes. We increase the time for free play. Again, it's not easy to have policies that can actually do that. Healthy urbanization, healthy communities. Decrease dependence on highly processed foods, which is, again, it's easier said than done. Because remember, we have 9 billion people on the planet who have to be fed every day. There is no way that you can do this. If you get rid of all industrialized and processed foods, there's no way you can feed 9 billion people. Right? So it's not an easy thing to do, but it's something we can think about and work on. I think what's most important is we have to make sure that our public, the policymakers and health professionals actually understand the science of obesity. And by the science of obesity, I'm not talking about, the science of nutrition or the science of exercise. I'm talking about the actual biology that underlies the whole problem of weight management and obesity. And I think not only can early detection and access to these treatments change the picture, and we are in India, for example, we are now just I believe 1 month away from some of these new medications becoming generic, which means that the prices are going to go down. There's going to be a lot more access to these medications. And what we have learned from the medications is that they not only reduce the risk of obesity itself, but they can actually reduce almost virtually every complication of obesity that you can see in patients who have obesity. So having said that, this is something I said a couple of years ago at a meeting in Korea. I said, if in 5 years from now, as a doctor, you're still not addressing and effectively managing obesity in your patients, I don't think you can claim to be practicing good medicine. Thank you.
Thank you, Dr. Arya. Great presentation, and you put things in context for us. Obesity is increasing. Does that mean that our slides and our lectures, they'll also become more and more obese with time?
What I can say is that there are more people giving lectures on obesity now than ever before, because it seems that obesity has become so popular that you cannot go to any conference without there being a talk on obesity, which as someone working in obesity is extremely interesting because I get to go to a lot of different meetings. So just this year, I've been to liver meetings, I've been to an obstetric meeting, I've been to a rheumatology meeting, I just got an invitation to an oncology meeting, I've been to obstetric meetings, so I get to go to all kinds of meetings in every field of medicine, because it turns out that now that we actually have treatments for obesity, every discipline is interested.
Any questions, any comments? We noticed that you had a slide where you showed that obesity is approved as a disease across the world. Yeah, the same thing we have in India as well, and I think we have Professor S.V. Madhu. The Endocrine Society of India has its guidelines on the management of obesity. Dr. Madhu, would you like to say a few words about that, sir?
Yeah, just to say that India also has, or the Endocrine Society of India also has come up with guidelines. You showed many. But the fact and the futility of management of obesity still continues. So I think that's all I want to say. But we have a guideline from India as well.
Any other questions, sir?
I'm pediatrician, so SJF mentioned some anti-obesity medications like Ozempic and other company, Lilly, can have effect on adolescent or pediatrics also, because obesity is a future problem with these children or adolescents is very common. So a role of these drugs.
Yeah, so these medications have now been approved for adolescents. So starting from age 12 to 18, they can be used. There are undergoing trials now, even starting from age 6. So these medications, as it is turning out, are actually surprisingly effective, but they also seem to be quite safe in those populations. So I think there is an opportunity. Now, I'm not saying that put everybody on these medications, but what I'm saying is that these medications can be part of a treatment plan, even in pediatric medicine.
Great talk as usual, Sharma. So we've had single agents, we have double agents, now triple coming. Are we going to see quadruple and quintuple kind of drugs coming? Where do we draw the line? And when you have so many hormones being either stimulated or suppressed, and also we have now others coming in to prevent muscle loss and so on. In one way, we are interfering with biology, isn't it? So as physicians, as conservative physicians, old-timers, we kind of think, are we doing too much to the body? And we don't have even 10-year data on these. And so while the going is good, but where do we draw the line with 50 companies getting into this research?
So part of the advantage of having 50 companies is that there is going to be a lot of research because every single company that wants to bring a drug to the market has to do all those studies that have to be done. So we are going to learn a lot more about these compounds. Now, when I say medications, as you rightly pointed out, they are actually hormones. Right? So what we are talking, so when we talk about Ozempic, we're not talking about a medication, we're talking about a hormone treatment because GLP-1, which is the hormone, is actually a hormone. GLP-1s have been around now, starting with exenatide for almost 20 years, I think it is fair to say. They have been largely used in diabetes, so these are not new medications in that sense. Now, what you've also addressed is the fact that now there is a development to try to combine these hormones. So we have, dual agonists and triple agonists, maybe quintuple agonists. That is also not uncommon for many other chronic diseases. When you think of managing hypertension, very often we use combinations. Even in diabetes, very often patients will be on 2 or 3 medications. Lipid control patients are often on 2 or 3 medications. So it is not uncommon that when we talk about these complex diseases, that we use multiple medications. And it turns out that the same is true for obesity. But this does not mean that everybody has to be on 3 or 4, 5 medications, because even the single medication could be enough for people. Not everybody has to go and lose 20, 30, 40, 50 kilos. For some people, just losing 10 kilos and controlling that you can do probably with one pill, maybe not even at the maximum dose, right? So these are things that we are now learning. These are things we are finding out. And I think in the next 5 to 10 years, as these developments continue, the pharmacological management of obesity, we are going to have a lot of science, hopefully good science, and we're going to learn a lot about how we can actually use these medications for the benefits of our patients.
So, Arya, comment from Dr. Mittal. Quick question. So, are we envisaging a world in which we have one injection a year for obesity? We already have angiotensinogen antagonists for hypertension, which is 6 months. Maybe it can become 1 year. We have inclisiran and other congeners, which again can be given once in 6 months. So do you envisage a world where we are going to tackle all the problems by just giving one injection a year?
Again, we have to watch what industry comes up with, right? I mean, we have gone from once daily to once weekly. Now we're going once monthly. Now there's going to be 6 monthly. Maybe in the future there will be something that they will change your your RNA or your DNA, and then maybe it becomes a permanent thing. So we'll see what industry comes up with. My hope for the future is that at least with these medications, we can prevent the most serious forms of obesity. See, we have enough people who are still running around, who are 30, 40, 50, 60 kilos overweight, right? We're talking, if you use BMI terms, you're saying BMIs of 40, 50, 60, 70. The heaviest BMI I have ever seen was 112. That should no longer happen. Right? At some point, I mean, the only reason somebody would reach that level is if they have never successfully been treated for obesity. We should be starting the obesity treatment much early in that history, and now we have the tools to do this. So I think that in the same way that we have seen, I remember as a medical trainee, we used to see a condition called malignant hypertension. This is these guys are showing up in your emergency room, their blood pressure is 240 over 150, and if you don't immediately lower the blood pressure, they go into kidney failure, they get strokes, they go blind. Today, that is a rare disease. Okay, malignant hypertension in that form we don't see anymore. Why? Because we have done such a good job of screening for hypertension and treating hypertension very early. So we don't see malignant hypertension anymore. I am hoping that with the proper screening protocols, with a better understanding of the science, with better training of doctors on how to actually manage obesity, morbid obesity or severe obesity will become a thing of the past. If I want to be even more optimistic, I can say that actually type 2 diabetes could be a thing of the past. Because what we have also learned is that with effective obesity management early on, you can basically not only get diabetes into remission, but you can actually prevent the development of obesity. So I'm very optimistic that these medications are not only going to be there for losing weight, for aesthetic reasons, they actually are going to serve a very important purpose probably in all fields of medicine.
Thank you, sir. We'll have a brief comment from Dr. Mittal and then we'll conclude the session.
Hello. 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 Sir, thank you for excellent lecture. There are many rural physicians, they are using Ozempic and there are many side effects are seen. So what is your advice to when there should be properly given?
Sure.
We'll discuss that in the panel discussion. We have a quick comment from Dr.
I'm going to leave the answer for the panel discussion. Yes.
Yes. So the issue is that we seem to be working very hard towards or evaluating drugs primarily by the action on total body weight. So you went from 15% to 20%, now we're talking of 25%. How far is this going to go? And we keep reading that the stock prices of the company went down because the weight loss was 18%, because 20% is already achieved by tirzepatide. Don't you think that's a very myopic approach to just look at the total body weight reduction as a criterion for success?
I'm grateful for the question. So I just had the pleasure of chairing the International Consortium on Health Outcome Measures for Obesity. And the first thing we decided was that weight is not the outcome. See, the reason you treat obesity is not because you want to get somebody's lower weight. No, the reason you treat obesity is to reduce the risk for the comorbidities and prevent the comorbidities, and that should be the measure of success on whether or not these medications are working. And it's not about maximizing weight loss, it is about maximizing the health benefits that people will get from the use of, evidence-based obesity management. And that's why obesity medicine is different from running a weight loss clinic. Practicing obesity medicine is not the same as running a weight loss clinic.
Thank you, sir, for the very interesting perspectives. And I think there's a lot of comments and questions around. We'll keep them for the panel discussion. We'll conclude the session now.
A great beginning to today's discussion. 100 years ago, 51 amino acids made a huge difference. 51 amino acids, insulin. Now it's only 31 amino acids. GLP-1 is just 31. In Indic philosophy, 31 is a very lucky number. Let's use that luck for the benefit of our fellow citizens. Thank you.